Welcome, everybody. My name is Angie Peacock. I'm a psychiatric drug withdrawal consultant and a healing coach. We are on our fourth of 5 interviews with the Alliance for Benzodiazepine Best Practices. Today is Dr. Alexis Ritvo. I'm going to read her very impressive bio so that you know who we're talking to, and then we'll jump right into the questions. So Dr. Ritvo serves as the medical director of the Alliance for Benzodiazepine Best Practices. She is board certified addiction psychiatrist and assistant professor of psychiatry at the University of Colorado School of Medicine. She has been the program director for the CU Addiction Psychiatry Fellowship since July 2020. She is also the co-chair of the Benzodiazepine Action Work Group with the Colorado Consortium for Prescription Drug Abuse, which she co-founded with Dr. Stephen Wright. He's the former medical director for the Alliance. She has a passion for psychotherapy, teaching and improving health systems and policies. Her professional goals are: number 1, to increase psychiatry residents' competency in evaluating and treating substance use disorders and physical dependence to benzodiazepines and general outpatient psychiatry, and 2, to improve patient access to psychiatric treatment for substance use disorders and physical dependence to benzos co-occurring with other psychiatric disorders. Thank you so much for your work, Dr. Ritvo.
Thank you so much for having me, and it's great to see you again.
Great to see you. The last time we saw each other, I was actually on the consortium with you as like a veteran's voice, but my plate was too full and I had to step down. I'm really sorry, but I love hearing about what you guys are doing.
We are always all juggling many things at the same time.
Many things. Yes, we are. So thank you so much. Okay, so you guys, I have tons of questions for her, and I don't even know if we're going to get to all of them because I know you have burning questions too, and I actually have a few patient questions that are specific, just about benzos. So let's start off at the very beginning. What inspired you to become a doctor and to specialize in addiction psychiatry?
So I have not chosen an original profession. I come from a family of psychiatrists, actually. So I'm 3rd generation. My grandfather was a child psychiatrist. Both my parents were psychiatrists.
Wow.
Who met at University of Colorado residency. And then I also married one of my co-residents. So I haven't, as my dad would say, I've not had an original idea. We haven't had an original idea in 3 generations. I figured if my parents and my grandfather enjoyed so much what they were doing and got so much meaning and satisfaction, it must be pretty interesting, and found that to be the case. And in undergrad, ended up studying social anthropology with a anthropologist psychiatrist, looking at the role of medicine and culture. And then specifically addiction psychiatry, that's my father's subspecialty. And my best friend growing up, who's basically my other sister, is in long-term recovery. And I, witnessed her really struggle and then at the same time really get her life back when she was able to accept her, that the way she was doing things was not working for her. And I just find it to be a field with not only great need, but a lot of hope. And that if you can hang in there with individuals, you can really see them help them find the important things in their lives and get them back and give them hope. And then, that led to interest in just prescription benzodiazepines, because even though the vast majority of individuals struggling with that, it's taking them as prescribed. The physiology obviously involves withdrawal intolerance and things that we're learning and treating in addiction psychiatry.
Well, so that makes me, this is not a pre-scripted question, but I always like to ask this, like, how did you figure out that benzos were a problem? Like, how did you figure this out?
Well, I think you see, I say we have patients come in and they're often of kind of, there's 2, everything's on a spectrum, but 2 extremes, which is some individuals where, they just want the pill because of the way our culture is set up of there must just be something that can solve this problem. I don't feel good. I want something to solve it. Hence how we ended up with our opioid epidemic. And then on the other end, some individuals where, the individuals that you're trying to prescribe a medication where you're also trying to help them see, we can find medications that may help stabilize your base, but they all come with risks. Mm-hmm. And the more we add, the more risks. And sometimes we start just chasing side effects. And usually most of the work that will be most beneficial is some therapy and getting them connected to therapy and other supports. So what, we want to use the medications to help stabilize their base so they can participate in therapy if they're not at a point where they're able to. But also using as many other non-medication things as possible. And then I think on the other end, you have patients come in who may be able or willing to do something like therapy, but but they're just not capable yet of participating. And so trying to really figure out when is a medication indicated, because it might be helpful. But with benzodiazepines, what we frequently see is, they work well, right? They work real well and they work quickly when they are started. And so people either come to know about them and ask for them, or on the other hand, in primary care, where docs have very little time with patients, a lot of patients presenting with a myriad of problems and distress, it's a quick answer. Whereas trying to make sure, how do I help them find access to a therapist that they can see, that they can get into, that takes their insurance, that might do the mode of therapy that would most benefit them. Good luck, right? Doing that in 15 minutes. And so, in a 15-minute visit, they'll say, well, I think this medication will help you, but then they don't know when they're going to follow up with them. They give them the default, 90-day fill or the 30 days with 2 refills. They assume that because either the patient asked about the medication or it's such a well-known medication, that they don't necessarily provide much detailed, informed consent about the risks of the medication. And then next thing you know, as we know from the studies, vast majority of people being prescribed these are getting them as continuation scripts. And the vast majority of people did not understand that definitely once they're on them beyond 2 to 4 weeks, it's only a matter of time before pretty much everyone will develop some physical dependence. And so I think it's just, unfortunately, a side effect of how our medical system's been set up. I do think our newer generation of doctors that trained either during or after the height of the opioid epidemic are more sensitive to this risk because of what we saw with opioids. However, I also think that risks the pendulum swinging the other way, where you have people getting stopped or tapered way too quickly. And then they become destabilized, or the prescriber enters into this like power struggle with a patient where they're not understanding, the patient is in distress. They don't want to feel this way. And they realize that this medication likely isn't helping long-term. But right now, the thought of doing something different and potentially feeling even worse is more terrifying than just trying to stay where things are.
Yeah. So. And that point right there that you just made, the thing that I see the most is, because I work with people that are tapering or off, is a doctor's failure to see withdrawal, the withdrawal syndrome. They medicate that, and then the person ends up on more. So my next question is, like, can you talk about the alliance? Like, what's your focus as medical director? What's your focus on the Colorado Consortium, maybe to help solve that problem?
Yeah. So I think, first and foremost is to make sure that we're filling in the gaps of the knowledge. Yes, they were supposedly taught this in medical school, but you're also basically drinking from a fire hydrant of knowledge in medical school, and may not, come back to this until you're the one prescribing. And then you're also still, in this steep learning curve of all the processes and things that you have to do in different clinical environments. So, filling that knowledge gap, making it really clear, giving prescribers the information about, like, these are the things we really need to think about with these meds. When are they truly indicated? And if they are truly indicated, how are we going to limit that they are short-term and not long-term? And then if we're going to engage in patients and tapers, how do we do that in a truly patient-centered way, and not make it some sort of power struggle? So I first, I knew of the Colorado Consortium for Prescription Drug Abuse Prevention. While the name doesn't fit exactly what we're doing with benzodiazepines, because it started with the prescription opioids, they have such a strong infrastructure, and they actually have a designation under the state of Colorado and receive funding sources from Colorado for provider education. So it became kind of a natural fit as we were looking to develop more of a network, first within Colorado, but then ultimately, I think the beauty of the pandemic and virtual world was that it allowed us actually to connect with people that were doing this work across the country, and could see that there was such an interest and a need to really focus on how can we increase prescribers' awareness, how can we look at advocacy opportunities. So in Colorado, we were able to pass legislation to limit the initial prescription that an individual would be prescribed of a benzodiazepine if they have not been prescribed one in the last 12 months.
Wow.
Unfortunately, I wish the rule had been set that it was for 2 weeks instead of 30 days.
I know, I was going to ask, was it 2 weeks or 30 days?
It was 30 days.
Darn it.
But at least it's still something. I mean, it's still now the question of what's next and making sure people are educated about that. But at least it was a initial step in the right direction. And it was just good to see that there wasn't
actually worked. The advocacy worked. Yeah,
too much pushback to getting it approved. And a lot of that was the fact that they built upon what had been successful with prescription opioids and applied some of that to these other controlled substances. And so I think, so that was the consortium side. And then through the consortium and Dr. Stephen Wright, who was at the time the medical director of Alliance, I started working with the Alliance. As Dr. Wright retired, they were looking for a new medical director. I tried to help them find a new medical director, and we had difficulty finding someone that had enough kind of knowledge of the issue with the benzodiazepines. And all of a sudden a light bulb went off, and I was like, I wonder if I'm allowed to be contracted, even though I'm full faculty. And it turned out I could be, since it was a nonprofit. And so then I became the medical director. So on the Alliance side, I'd say we work more on the kind of national level, trying to help, first prevent the problem by helping, how do we decrease initial prescribing? How do we, do things like collaborate with the FDA and other national organizations? How do we work on, we've tried various ways to try to encourage development of a national prescribing guideline for benzodiazepines. We haven't yet succeeded in getting the first part approved. Actually, our hope is now that the FDA has approved developing a deprescribing guideline, which ASAM's taking up, that once they realize the limits of the existing evidence, that we'll be able to say, well, here's why we even more need a national guideline. So that's kind of, I think we're all kind of trying to work in this space at the various local, kind of state, federal levels, through education policy, public awareness, and just make as much impact as we can.
That's awesome. Now, speaking of which, this is a tangential topic, but the other day I was listening to Vinay Prasad from UCSF. I don't know if you ever heard of him. He's a doc. He's an oncology doc, but he's like super into research and stuff. But anyway, it was just some silly podcast I was listening to, but it was so fascinating to me because he was interviewing two other doctors, and they were all talking about CME, and they were like, how dare you, insult our intelligence that we're not up to date on the latest research. Like, I don't have time. Don't tell me to sit and take some stupid test. And I'm just thinking back to our Bernie conversation where Bernie said, you guys have trained 4,000, doctors, and what is it? The statistics say like only 10% will actually use. So
it's
where's the hope? Give me some hope. That's what I need.
I think the hope is you have to do, and this is what we saw. I know I sound like a broken record being like, I think we have to take what we've learned with opioids and what was or wasn't successful and try to apply it. Because we have a decade worth of, approaches. I think it's a combination of approaches. I think CME is great. It's most helpful when people feel like, is it given by someone they know, or if they have a question, do they have someone they can outreach and follow up? Can you provide some sort of mentorship? I keep looking for opportunities to set up more of kind of a hub and spoke kind of model is what they call it with opioid treatment, where I could provide consultation to primary care or something. Because obviously I, as one person in even just the system I work in, the University of Colorado health system, can't see all the patients that are interested or motivated to try to do a benzodiazepine taper. Right. And it just wouldn't be an effective way to get the work done and try to impact the most people. But what I could do is try to provide consultation, is something I know you're familiar with, to more providers. And then for the more complex cases, that's when you refer into the hub, get more specialized care. And then once stabilized or kind of on a clear trajectory, you transfer back out to, say, the primary. So looking at different models, I've actually contacted individuals through UCSF. They have for substance use what's funded called a substance use warm line, where any provider can call in to get basically consultation about a patient with a substance use issue. And I was like, do you guys ever see a need for this with prescription benzodiazepines? They're like, we do get questions about it. And so the head there was like, well, if I see a funding opportunity come through, I will let you know and we can collaborate, because I think that would be a great way. Because I think that's what people want. Like it's not that they don't want to help. It's that, especially in primary care, I mean, when you're trying to tackle so many things and help a patient with so many different things, and then you have this thing that is full of so much, I mean, it's just such a complex issue of someone's feeling distress. They're taking a medication that was supposed to help that. Now there's a question of it's making it worse, but it's causing a myriad of symptoms, some of which seem maybe, obviously related, many don't. I mean, this is where I've likened this protracted withdrawal, which I know you've heard now.
I'm well aware.
Yeah, bind, as we're trying to kind of name it, that I think it's kind of like long COVID, where we need to accept because everyone's nervous system is unique, that it presents in many different ways. And there's a waxing and waning, and we need more research to kind of pin down what the most core symptoms are. But just because you can't see it and we don't have a test for it doesn't mean it doesn't exist. And I think we've seen that with long COVID, because we had so many patients present acutely because of how quickly, COVID onset. So again, that's another model I think we need to keep in mind and see how we can leverage, some of the things they're doing to get more research and more focus to do for individuals that have been negatively impacted by benzodiazepines.
I love that. I have also found in my own work that it's easier for doctors to hear you or understand, or policymakers, when you piggyback on another topic that they do understand. So everybody, it's when you say suicide or major depression or socioeconomic, they understand these concepts, and you have to like slide in our topic with that. Otherwise they're like, what do you mean benzos? What are those? Never heard of it,
Yeah, exactly. I think, so opioid epidemic, unintentional overdose, suicide, long COVID, all those.
They can hear those. Yeah. All right. So let's get in the weeds. I see lots of clients stuck on benzos. I see a lot of fear. Like they're afraid of their cuts. Very, very rarely is it only one drug. Sometimes it's multiple. So I guess, can you take us through the weeds? Like, first of all, what's wrong with benzodiazepines? Just for those that are listening, that there's lots of caregivers and parents in my audience. Like, what is the problem with being dependent on benzos? And then how does a person successfully deprescribe them?
So the problem, like I said, that, they work initially very well. They are helping increase, they have this nice unique mechanism. So GABA, your main inhibitory neurotransmitter, helping quiet down your nervous system. They don't just increase GABA, they actually have a unique mechanism where they attach to GABA and increase GABA's pull of chloride and the negative ion, and increase the negative charge of the GABA receptor. So that's great. You're feeling nervous, anxious, you're having trouble sleeping, inhibiting your nervous system is going to help with all those things. Unfortunately, what happens, and we don't know why, for some people it happens sooner, for some people it happens more severe. We always know that if you're taking a higher dose, you're taking it for longer, you're taking more than one in that class, you're taking it in a combination with other sedating meds, that all those things will increase your risk of a withdrawal and a more acute and potentially prolonged. But other than that, I've, as you have too, seen so many people that it was like they were taking what many would think is a lower end dose, even though it's of one of the potent benzodiazepines. So I think what people don't get is you have this very powerful med working on your nervous system, and it really I mean, they were only studied often for a few weeks, most of them for up to 4 months. Um, Not with the indication of chronic administration. And when you administer it chronically, our nervous system always wants to create homeostasis and balance. And it's saying, well, you're sedating me a lot. And my goal is to make sure I'm awake, alert, functioning, breathing, able to run away if I need to, if there's a threat. So I better upregulate all the excitatory neurotransmitters to keep myself doing all those things, because I've had this chronic increase in how much kind of inhibition I have. Where if you want to put it in car terms, like if you're using a lot of brake, you're the car kind of starts trying to use more gas. And so as a result, what happens is your natural endogenous GABA decreases, because they're saying, well, I have so much more activity going on in my GABA system. I don't need so much. So I'm going to back off on how much natural endogenous GABA you have. You get a down regulation or decrease in the GABA receptors as a whole, again, trying to decrease the level of inhibition in your system. And so overall, you actually get a decrease in the inhibitory system, because it's trying to overcome being so inhibited. And at the same time, it's also increasing all the excitatory. And so that's why people start to feel sometimes more anxious, or now I can't sleep, or I'm more irritable. And so this is the building of tolerance, right? Because suddenly you need more to get the same effect, or the previous amount that had effect is not working. They also have found some evidence of what they call uncoupling of the effect the benzodiazepine has on the receptor. So it stops being as effective in pulling the chloride ion to the receptor. So again, you would need more to get the same effect of previously. So you basically just get this breakdown in the system when you start taking it more, where not only you need more to get the same effect. It's actually, it's chicken and egg. You start, it's easy for people to be like, oh, I must just still be more anxious or not able to sleep, the two main reasons it gets prescribed. But more often than not, it probably is that you've built tolerance, and now those symptoms you started it for to treat are not only untreated, they're made worse by the medication.
And that's the thing. Because even me, 7 years ago, I said, I need these medications. I have bad anxiety. That's what I have.
I feel worse if I don't have them.
Yeah. And in my own story, I thought it was the caffeine I was drinking, so I quit caffeine. And then I thought it's the cigarettes I'm smoking, so I quit the cigarette. I never thought it's
which probably weren't helping, right?
No, and I'm glad to get rid of them, but it wasn't the root of the problem, because it is like that. Like but I'm anxious. What do you mean it's the benzo causing it? That's not an idea I've ever heard.
And that you feel, I think what we as providers forget when we go in and try to tell people you shouldn't be on these long term, or I'm worried about how these will affect you, is that people were started on these by a prescriber because of their anxiety or distress, or even though it's not indicated for trauma, a lot of people get put on it because of the distress and anxiety they feel due to trauma, because it's so prevalent. And the idea of, well, if I don't have this, what am I going to have? At least, the devil you know is better than the one you don't.
Yes.
I could feel worse than I already feel is a really scary prospect. Or coming off of this would make me feel worse than I already feel.
Yeah. And I feel like that's unfair to patients to not warn them that it's, we're going to put you on a drug that we don't know what's going to do long term, and we don't know when you'll be able to come off of it, or if you ever can come off, and how hard it could be. That's not.
And we don't know enough. We need so much more research about, as I've been, I oversee the curriculum for our third year residents and our addiction psychiatry fellows in addiction. And then I always end up making sure they have at least one lecture about benzodiazepine tapering and bind, if not more. And I tell them, I'm like, you will always do better to go slower, because we can have some prediction of who might have difficulty tapering, but you will do much better if you try to help a patient see that we do a low decrease, they tolerate it, and we get their buy-in that this is a process they're going to do okay with, and that we support them in it, rather than try to take it away too quickly, have them feel horrible, destabilized, not be able to work, and then they're too scared to do anything further.
Yeah.
And so, it's a marathon, not a sprint. And the end goal, if we can get people off, great. But if we can get them on less, that's still a huge win. And it may be that we get people down to a little bit and find that right now we can't completely stop it. That's okay.
Yeah. So most of these groups online, which is another tragedy to me that I couldn't believe, like, what do you mean there's patients online tapering a drug without their doctors watching? Like that was shocking to me, especially because I had a degree in psychology at the time and I went to a medical school, and like I was like, what do you mean? Where's the doctors at? I don't understand. So most of the advice in the groups is either a daily liquid microtaper. So patients will have 300 milliliters of water and they taper 1 milliliter a day. Sometimes they hold for holidays or birthdays, or they just don't feel good.
Yeah.
Another recommendation is 5 to 10% every 2 to 4 weeks. And then I see a lot of patients, they start out like really low, like 2%, just to see like, how's my body going to react? Like, I'm not really sure.
Yeah.
So those are the 3 ways that I see mostly. And people either do liquid, they get it compounded, or they do tablet where they weigh it and then they scrape off a little bit and they do it like that. So tell me, what do you think of all that? And like, what is the recommendation and what are you teaching?
Yeah, there's so many factors that depends. I will say many of the patients I get referred don't have either the cognitive ability to do it. So like I have some elderly patients that are already showing signs of probably are developing dementia, in addition to being on a benzodiazepine long term, which is not helping their cognitive impairment. Or I have some other patients where just their health literacy level is not one that they they're going to be able to understand or have the resources to do something like microtaper. So then you're doing the best you can with what you have, right? So for some patients, that let's get you over to Valium and let's decrease by do you feel like you can quarter the pill? Do you feel like you can, at least half it? Can we get you a liquid preparation? Because at least there is Valium does have a liquid preparation. Clonazepam does too. I don't cross taper people to clonazepam, but if they're on that and they're leery of going to diazepam, we might try to get that. So it's kind of, there's always so many factors contributing to what you can do. With the other ones, of course, like all things, we need more research. Ultimately, I think we need to develop a different formulation.
It's a great idea. Wow.
That has a much smoother long-term decrease, because no matter what, when you're taking something by mouth, you're gonna have these fluctuations, and some people, as we know, are extremely sensitive to those. So I think it's what works for people. I think the other part we just can't, you can't quantify, but you can observe, and people have to try to figure out for themselves what works, is trying to weigh the risk and benefit of, the longer this is going to take, how much is there psychologically? Does it become reinforcing of just constantly trying to be aware and scanning and heightened awareness of what am I feeling, thinking all the time, and am I feeling horrible and then withdrawal, versus trying to go a little faster? But at some point, everyone just has to try to do the best they can for themselves. So what I think is best is supporting the patients and walking them through some of the options, and trying to make sure, if they're like that, they're limiting the variability as much as they can, with whatever approach. I would say for the patients I have that are not going to be able to either shave a pill or pipette, or then I'm just trying to help. And if I can enroll a supportive family member to help with a pill box and with cutting pills and keeping track, that's been a really useful thing. And then trying as best I can to at least stick to that, like 5 to 10%, 2 to 4 weeks, but always telling them, like, if you start to feel like things aren't going well, then we'll just pause. Like, there's nothing wrong with pausing.
Right.
That, and I will regularly tell patients, like, just so you're aware, I hope you're celebrating the fact we've already decreased you by like 25%. That's not a small amount.
No,
And that's that much less that your body's dealing with. And also making them aware, like I said, we may need to pause or stop when we get near the bottom. You may need to, take a break. We may find that for now, this is the set point your body's at, and it would be greater risk to get you completely off than to keep you on a little bit, if that, while always trying to work with them for what their goal is.
Yeah. I like that you said that. I go through that a lot with my coaching. Like, I want to identify, like, why do you want to taper? What is your hope? Who are you going to be after this is over? Who were you before? That's really important to me, because when a person hits tolerance, or if they hit a wall, or if they're like really struggling, I need to know that to help them remember, like, this is why I'm doing this. I am curious. I want to know what it's like to feel good again. I want my life back. I want to feel better. There's all these reasons, but also I always recognize that, it's not so cut and dry. Like, the groups are great, and they're double-edged swords, because like there's some really scary stories in there, and it scares people, and then they want to be talked down, but there's no like right way to do it. It's like whatever way is going to work for you, including your belief system. Like, I find that is not a small thing. Like, if a patient thinks, I can't do this without a doctor's help, then we have to go find them a doctor. A lot of them are like, I don't want nothing to do with a doctor. I'm going to do this myself. And the water taper is the only one I can cognitively comprehend. And that's what I'm going to do. Like, so I just want to make a point. Like, there's so many different ways. What do you think about that?
I think, ideally you would have someone involved, or whoever's prescribing is at least willing to try to learn some more about benzodiazepines. But you have to meet patients where they are. I mean, this is where I also think, and I'm like, I can always use more and more training in it. But I don't know if in your training you did much motivational interviewing, but I think
do that all the time.
It's like at the core of all of it. It's not, this is about how do we help the patients, clients that we work with identify what's important to them, how to help them move towards that, what's getting in the way of making that change, where's their ambivalence. Our goal is not to tell them what's right or wrong, or exactly how to do that, but to recognize that they're the expert in themselves, and that we can offer some other information that may help them in pursuing that.
That's it. And also, and that brings me to another question. I see fear is so much of it, fear and suffering. Like, that's like, these are not, for people listening that have not experienced this, it's very intense. It's like, for some people, it's very severe. It's, minute by minute, it's like very hard. Even when they make a tiny little cut, which seems like so insignificant to us, like, they feel it, So I work with a lot of fear and a lot of suffering when it's really intense. So can you maybe talk about that? Like, when people are on multiple drugs, or it's really, really intense and severe, and their intolerance, things like that. What do you see as helpful, or how do you kind of work with those situations?
I mean,
it's not everyone.
Yeah. I think, one, making sure they have supportive people in their life, that they can just, at least tell what they're going through. I mean, I know how many people say, my family doesn't believe me, or my doctor doesn't believe me, or my, whomever. So that's a very invalidating place to be, and just contributes to your sense of fear. So I think the importance of, you need to feel connected and supported, because loneliness will only drive that sense of fear. I think it's really important to find the things that you still get some enjoyment from. And even if you can't do them to the same degree, making sure to make time for that. And that includes one of my colleagues that's a geriatric psychiatrist, and we supervise on the same day. One of her favorite questions to ask patients is, when did you last go on a walk in the sun? And then that will be her prescription, is, go on a 5-minute walk in the sun. And so, I think remembering it doesn't have to be, you don't need to be able to run a marathon. You don't even have to run. And if walking's hard, you can sit in the sun, but find those things, those moments, the small things that are meaningful, ways to connect to other people. Try out some other skills. And we have some good evidence for things like mindfulness, and for some people, the like, oh gosh, biofeedback
Yeah.
works well, where they get a little more, things that they can actually see the variability in their heart rate, and learn to control it some. I like to teach my patients about the diving reflex. So it's called, have you ever heard of that? The mammalian diving reflex. So you have temperature sensors under your eye. And if your body, if you put something that's cold on them, so like a cold wet washcloth, you can submerge your face in water, if you don't mind that kind of thing, in cold water. Or you can do like a Ziploc bag with ice water, and you make sure it goes across the skin, and you take a deep breath and you hold it for a little bit, not so long that you're uncomfortable. It triggers your body to say, oh, I'm diving into cold water. Wow. And I need to preserve my temperature, core temperature. So it decreases your breathing rate. It decreases your heart rate. And so it's helping tell your nervous system, like, I need to chill out so that I can preserve my temperature for being under cold water. And so it's actually a really effective way to try to just quiet down your nervous system. And there, you can look up YouTube videos. There's this one guy where he actually, on his smartwatch, shows his heart rate coming down as he does it. So that's a useful tool to actually be able to give people if they're in a moment of panic where previously they might have taken another benzo, or they feel like nothing is going to help.
Yeah, that's really cool though, the way you said that, because even with my own withdrawal, I looked for ways, how can I trick my nervous system? It's weird. It was intuitive to me. And I did cold showers, and I have clients now that do cold dips. Not everybody can do that, obviously. So this is a quick way to do a cold dip without the actual dip.
Yeah. Keep a wet washcloth in the freezer, or a little Ziploc bag of ice water.
Whew. So that's a good question though, that I didn't prepare beforehand, but what is happening? When we are tapering and we're withdrawing, I guess we're feeling that. I always say we can look at it like an injury, but you can also look at it like it's part of my healing. My body's trying to rebalance. So what is going on as we're decreasing, and then maybe when we're off and we're healing and there's bind, what do we know about that? What is going on?
I mean, I think as you're decreasing, and this is where there's a Mark Horowitz, one of his papers has a nice graph where he shows this is why you want to make smaller decreases, is because each time your body needs to set a new homeostasis. If you do a big decrease, then from where you were to where your body needs to create a new homeostasis is much greater than making a bunch of small decreases. And so it's just that your nervous system is, trying to recalibrate for how much inhibition do I have and how much excitation, what do I need to keep, you awake, alert, breathing, functioning, able to run away if you need to, able to assess your environment. And so, I mean, which is the argument for overall smaller percentage cuts. But I think, again, everyone's nervous system is so unique. It kind of varies what that means. So I think that's the kind of acute withdrawal phase. I think with bind, we don't know yet. And this is where I parallel it to long COVID. And actually with alcohol withdrawal, we know this too. There's some predisposing factors. In alcohol withdrawal, they actually, and I'm now, someday I will pursue at least outreaching to people that have studied this to be would you look at this in benzodiazepines? But in alcohol withdrawal, there's some research on the genetic markers in parts of GABA that predict who's going to have more severe alcohol withdrawal. Alcohol is not acting on the exact same place on the GABA receptor as a benzodiazepine, but it is acting on the GABA receptor. So I have to wonder if there's a similarity, that why we see some people that are just so exquisitely sensitive, and some of them after very short periods of time on not a lot. So that's where bind and thinking that there's some sort of injury, as we've been working on getting papers published to kind of put forth this idea, one of our senior colleagues, faculty colleagues, his name's Dr. Peter Martin, he's at Vanderbilt, was saying, it's probably both a neuroadaptation, so it is your nervous system trying to adapt, as well as there probably is some injury or neurotoxicity. Is it that your body becomes impaired at reaching that homeostasis, or the rate at which it reaches the homeostasis after you make a decrease, that it takes longer. And what we don't know is the kind of why, and to what degree. Like I said, it seems to be a genetic, there's got to be some genetic predisposition. Like most things, it's probably a combination of genetics and then other hits to the system, whether that's, other physical health problems, other medications that you're on, just things that are, unique to each person's biology and physiology. And that probably then also explains why, we get this, like they're seeing with long COVID, this waxing and waning. Someone can feel like they're doing really well. And then if their body is under stress because they get sick, because they're stressed, because they have something coming up, or they start not sleeping well, that some of those symptoms are going to return. And it's, it's not because they're making it up or it's unrelated. It's because, your system, you've now overstressed the system, and it can no longer compensate as it was before that new stressor came on board.
To someone who suffered from this for years, unfortunately, it felt like to me, because I was trying to figure it out. I even took like anatomy and physiology class to try to like learn more about the nervous system, like what is happening to me. But it very much, I don't think we know. I don't think we're any closer to knowing. We're really far away from it, honestly. And it made me be really humble. Like, we don't know anything about the human body. What are we thinking?
And especially the nervous system.
No, especially the nervous system. But what it felt like to me was that, and what it's felt like over time, because I'm 7 years off now, but I still have this hypersensitivity to stress. I still feel extremely overstimulated in certain environments. And it feels kind of raw, like there's not enough something there to calm it down. Like something is missing that's supposed to tell me everything's fine, because there's no reason I should be anxious right now. I'm fine. I want to go to Whole Foods. There's no fear there. What it's not a tiger, it's Whole Foods,
Yeah.
But anyway, so that's what it felt like. But it also has felt like some kind of excitotoxicity. Now for me, because I was cold turkeyed from 1 milligram of Ativan, which is not a small amount, I understand what you're saying. Like you drop from 1 milligram to nothing. Your body's like, what the hell did you just do? But do we know anything about excitotoxicity, like the glutamate, like too much?
I mean, we know that it's going to increase, right? When you have this inhibition, and we know that, this is why people are at risk for withdrawal seizures as well, is that you have that increase because it's trying to overcome this chronic inhibition. And then if you take away the chronic inhibition, suddenly it's unchecked and the nervous system's overexcited. I mean, that's why the most severe acute withdrawal symptoms and life-threatening is a seizure.
Where it comes from, yeah.
And so, right, that's the most kind of severe example of an overactive nervous system.
Yeah.
And then some people are, just also biologically predisposed to already have a more reactive nervous system, whether they're the people like myself. I'm hyper-reflexic, obviously, like I can make my arm jump just hitting it with my hand. Wow. So some like certain ways, I actually before medical school, I was a research assistant doing evaluating patients with psychosis and their family members, and trying to look for commonalities among even unaffected individuals versus individuals that had schizophrenia or schizoaffective disorder. And they could see there were certain traits that like a family member that was not affected might have. But it was probably a combination of traits that contributed to kind of an overloading for that individual. And I guess, I think something similar probably applies. There's some people, I'm always amazed that even though I'm like, please don't stop your meds cold turkey, even their antidepressants, they still do. And they're like, no, it's fine. And I'm like, okay, one, you've probably like, please be aware next time, please don't do that. But also there are some people that do seem to be on the less sensitive end. That's like shocking. And then other people where you're like, you are, extremely sensitive, which is probably in part, medication duration. If you've had any kindling from like previous cold turkey stops or abrupt, really big drops. But some of them, again, you're like, I can't explain it for that, but all I can say is there's something in your unique physiology, nervous system. Maybe it's like, yeah.
And I think like it's also like part of our personality or our ability to deal with these severe symptoms. I have some clients that are like, I can't do this, I won't do this, I'm not doing this. And I'm like, okay, well, we have to, like, how
Mhm.
can we, and we work through that, and it's incredibly hard. It is so hard. But I think even like our disposition to like handle it, like me, I was in the military, so I am used to pain, not pain like this, but like
Mhm.
I've worked that muscle before, in some ways, but it's so hard. Okay, so my next question is, there's a controversy between, if you're on multiple drugs, do you do the benzo first or the benzo last? What do you
I mean,
think?
I think like most things, we don't have the research to say for sure. I think the right medication to do is the one that has the patient's buy-in. And there's nothing to say you don't start with one and maybe you pause if you start finding that they're feeling the withdrawal symptoms more severe, and then you work on another.
Mhm.
Um, I will say, on the one hand, I mean, I am in agreement that our society as a whole is greatly over medicated with psychiatric medications. And I also see the portion of people that, without some of these meds, not
Mhm.
usually long term benzodiazepines, but without some of the meds, they wouldn't function. Or in the case of some of my patients that suffer with substance use disorder, that if, I may initially have to stabilize them on more meds for um, trauma and other things, just to allow them to be able to get into doing the other work and get enough time without the other substances, and then taper them off these as many
Yeah,
meds as they
later.
can. So
Mhm.
it's never all or nothing. I think each individual has to figure out for
Yeah.
themselves which medications do the benefits outweigh the risks, and which ones is it that the side effects or the risks of it are greater than they want to do, which means needing to have a provider, which I know is much easier said than done, that is able and willing to have those discussions
Mhm.
of, so thinking about, sometimes we use side effects of certain meds in our favor, like a med is more sedating, so we may not want to take that one away if it's lower risk than the benzodiazepine. So maybe you leave the more sedating med to help taper the benzodiazepine so that you're less likely to disrupt sleep, or you leave the med that is also helping prevent some anxiety, um, uh, to get down. So some of it is, I guess I will often suggest we try to taper what seems like the higher risk med. So if they're on a lot of benzo and opioid, then I'm going to say ideally we should do one of these, because we know this is a big risk for unintentional overdose.
Right.
Or we know, you have breathing problems, and this is also further risk.
Mhm.
If it's not that obvious as far as what an acute risk is, then I think, always, deferring to a patient. And I just yesterday overheard, I was not my patient, but one of the patients a resident was staffing, where they had a plethora of meds, and they're like, where do we even start? And they said to the patient, these are the ones we think are like the most likely affecting your thinking and your energy and your focus.
Mhm.
Which one do you want to try to decrease first?
Yeah.
They chose, and they came back 2 weeks later, and it was like the resident was like, this was the best visit ever. Like, they were saying, my friends say I'm acting more like myself, they're thinking more clearly, and that was just from decreasing one of
One.
like a
Wow.
plethora of medications they were on.
Wow. Yeah.
And it was such a good experience for the prescriber, the patient, everything, and it was like a very collaborative process.
That's good. That's good. I like that. Well, everybody in the office, or I'm sorry, everybody in the audience, we have only 7 minutes left. So if you have a question, send it. I think we got one question, but I think it's about an antidepressant. Let me see. Oh, something about, have you heard about the COMT genetic mutation? I have it. My body is missing an enzyme that breaks down norepinephrine. What do you know about like genetic variants, like the COMT? I know MTHFR is always popular. I don't know. You might not be able to answer that. You're not a genetic,
There's
but is there any?
Yeah, I mean, they keep studying all these psychopharmacogenomic testing. What I tell patients is there's not enough evidence yet for it to be the default recommendation that we test it in patients. It can be helpful in telling us something about either how patients metabolize medications. That's how most of it works, is it tells you about someone's unique like liver proteins, and most of our psychiatric meds are metabolized through the liver, not all, but most. And then there's a few variations, like there's a serotonin transporter gene, there's the COMT, there's MTHFR, which seem to play a role in effectiveness of some of these meds, but many of those don't yet have enough evidence that, for instance, Medicare will cover. Like Medicare is very specific of which ones they'll cover, and it's based on, is there enough studies to say that this, that the number needed to treat is beneficial, or it's going to make a benefit. So it might with I actually haven't gotten information back for any patient where it was on the comp. I would have to like look that up more. I mean, I think it would tell me, okay, maybe a medication that's targeting norepinephrine is not going to be as effective. But that doesn't mean for sure. I mean,
yeah. I think we're so in the infantile stage of this. We don't even know.
Yeah. And what we don't know a lot of times is just because we know something like mechanistically, like, oh, you're deficient in this, it doesn't always translate to to the effectiveness of a medicine or the side effect. Like there's often so many factors. Yeah. So I think it's one piece of information. Unfortunately, we don't yet have the test that says this is the medication that will be most useful. This is the one you should avoid. I hope
don't know. I even think genetically, it might not even matter what genes you have. These drugs are that powerful that they alter your nervous system. Everyone's, or maybe to a point for some. And I don't know. I'm just saying, we don't know.
Yeah. I mean, we don't know. I think there, unfortunately, in all of medicine, but especially anything involving brain and nervous system, just like we've seen with a lot of meds, they come around, we see what they're useful for. And unfortunately, then we learn the things that are less helpful or that are risks with them. Yeah. And I think certainly a big thing has been, really, I think, hopefully teaching prescribers how to do a more gentle taper with patients on any psychotropic meds. Yeah. So that, because we know that the more gentle you are, the better a patient will have in reachieving that homeostasis. And it will be easier for us to delineate what is a return of the symptoms we started this medication for and what is actually just some discontinuation or withdrawal from these medications.
That's a good point. I wanted to ask you about deprescribing. So I've been following the Google alert deprescribing for about 6 years. I can only tell you maybe 3 times in all those years have I seen anything about deprescribing of any psychiatric drugs or benzos in particular. So I think in Colorado, you're working on a deprescribing clinic. Maybe that was a secret. I don't know.
Not a secret. I mean, it's more of trying to figure out when and how to do it, because as you know,
many forces opposing that, or money needed. So where do you see the future of deprescribing, especially benzos? Is it happening? What do you think?
Yeah, as I mentioned, well, one, I think is hopefully some development of medications that lend themselves to helping more people more smoothly deprescribe without having to go to all these lengths that are very time consuming and resource heavy, and not everyone can do. And even those that do, I think, lose a lot of, have to use a lot of energy on it. So I think drug development, I think while a deprescribing clinic would be great, maybe for the more severe cases, I've decided that actually the higher yield would be initially figuring out how do we support primary care and general psychiatry, but the rates of prescribing are really have increased in primary care. They've remained static in psychiatry, and at least where I practice, we almost never start a patient on a benzo except for potentially giving them that short-term script for an acute stressor. But we inherit many patients that have been on chronic benzos, often start in primary care, not always. And so how do we support primary care who are on the front lines of how do we deal with, life's stressors and distress, and so that they feel comfortable engaging in this process with patients. So that's where I'm thinking that's like hub and spoke model, doing some sort of, offering mentorship or consultation to providers. Because that's what we also saw, again, to sound like a broken record, but work well with in opioid use disorder and buprenorphine and getting people more access was you meet them where they are. And with benzodiazepines, most of them are prescribed in primary care.
Yeah, I like that as the primary focus of where can we target and make the most good. Yeah, I like that.
And help the most people.
Yes. So last question, a person's asking about, I'll just say in a general way, updosing, rescue doses, playing with the dose. Can you tell me about that?
I think, it's just really difficult because if we know you've developed tolerance, then we don't know where the ceiling is. Like, right, if you keep updosing, you're going to just continue to build tolerance. I think what you do want to try to do is work with the medication in your favor. So figuring out, do I need to dose this more times per day? So I can't tell you how many times the patient, I'll say, well, let's try as we're cross tapering to Valium, let's try 3 times a day Valium. Let's try 4 times a day. The other thing is that depending on what the symptoms are, for some of these meds, the anti-anxiety effect is shorter lived than the other kind of anti-withdrawal effect. So, if you took your vital signs, they wouldn't necessarily go up and show signs of physical withdrawal, like as far as your heart rate increasing or breathing, as soon as you feel other things like the return of anxiety or irritability or maybe some of the other symptoms. So I think trying to think dosing more times a day, not necessarily changing the dose. Not to say never if someone's in just absolutely not tolerating it. But I think what would be better is go slower, do a slower decrease, pause, stay on that longer, and then continue rather than trying to, go back. Plus, psychologically, it just doesn't make anyone feel good to have to feel like they had to go back.
Yeah. Well, excellent. Oh my God. I could talk to you another hour.
I know.
We're both have to stay on schedule. I'm so sorry we didn't get to the other questions, but thank you all. Thank you for being here. Thank you for your work. I feel like one day we will get our reward because we're changing this and you're at the spearhead of it. So thank you for all your work at the Colorado Consortium. I'm not even going to try to say the rest of it and the Alliance. Thank you all for joining us. Next week, we have Adora from the Benzodiazepine Alliance for Best Practices, and she's going to talk about advocacy and how you can get more involved. So if people want to follow your work, I'm sure you don't want multiple emails, but how do people find out?
I'm on LinkedIn, and then through the Alliance LinkedIn and the Alliance webpage where we post, kind of all the things that we're doing, and when we have presentations coming up and things that people can be involved in. So those are probably the best ways to get a hold of me. So so great to see you again. And
you too. Thank you. And last thing, I always like to end on hope. Can you give us 2 sentences of hope, and then we'll hang up?
2 sentences of hope.
Or
one. I think
anything.
I mean, any decrease is an improvement. And I have seen people who had an abnormal cognitive screening normalize as we got them on less benzodiazepine. So I have a lot of stories of hope of people feeling so much better just as they get down, not even that they have to be completely off. So don't underestimate and look for the support and the reinforcement. Through the Colorado Consortium, we've developed a peer support curriculum that we're starting to train people in to help with that. So look for those supports, because I think that's such an important part of surviving in this world and feeling like you can manage.
This is it. Thank you so much. All right. Have a wonderful day. Care. Thank you, everybody in the audience. See you later. Bye.